So today we'll discuss the importance of proper documentation. We discussed this in our first installment, that is a critical area in the healthcare reimbursement arena that is utilized by most insurance plans as well as auditors as the foundation for reimbursement. So we'll talk about some documentation techniques and tips. We will also discuss the CPT codes that are used to report the HIV testing and screening codes. We will also look at the modifiers that are commonly used to report these services. This slide provides an overview of all of the acronyms used in the presentation so that you will have something to refer back to as we're advancing through the PowerPoint. And so let's begin our discussion by talking about documentation. So for your HIV testing component, there are two phases of the documentation that you should ensure are in a patient's medical record. So every time a patient comes in for that first visit, you must make sure for those encounters where you will be doing any type of HIV testing, you want to make sure that there's a consent form in the record, and it varies state by state regarding the content and the type of form. But if you go on to your local Medicaid agency's website, they should have a template that they provide to give you some guidance for you to use. Specific to the patient's visit, when they come back to you for their results, you want to ensure that you document the patient's test results. Also of importance is you want to ensure that the test results are properly communicated to the patient, but you also want to make sure that you document the method that you communicated and the time frame that this information was communicated to the patient. When the patient presents for a subsequent visit, you also want to ensure that there is written justification for all second and subsequent visits that the patient presents for as it relates to any type of testing or any type of counseling that may be necessary. And so you want to make sure that this information is properly documented in the chart. And in terms of how it should be documented, you want to be able to tell a story. So for that very first visit, it should clearly state this is the patient's first visit and the reason for that visit. And this was discussed in the PowerPoint Series 1. So if you missed that, please go online to the Health HIV website and download the PowerPoint slides for that presentation, along with the Q&A questions, which will be available to correspond to those slides. So let's just digress back to this. Also for HIV pre-testing where there's no counseling involved, written documentation should clearly state when there was any type of counseling that was provided. If for any reason the patient declines the HIV test and this visit is just for counseling, you want to document that the patient declined the test. They also have to sign their name next to their reason for declining, and you want to make sure that it's properly dated. Just in terms of an HIV counseling visit, the counseling visit documentation must include a follow-up care plan, and if there are any indications for further counseling or further testing, or if you're referring the patient to another specialist, you want to make sure that this information is documented in the chart as well. Some additional documentation tips. If the results of the test are positive, you want to make sure that you document any preliminary or confirmatory positive test results. There should be a care plan in place and as part of that care plan, it should include any medical care or supportive services, and this should be properly documented in the medical record. If there's going to be any continuum of care associated with the patient's visit, this should be documented in the chart. Prevention and risk factor reduction counseling is extremely important, and this should also be documented in the medical record. So these are all elements of a medical record that should be documented when the patient has a positive result or when it's confirmed that they have the HIV or AIDS infection. In some states, there is a partner notification form, so you should check with your local Medicaid state agency to see if that is something that is in place in the state where you are practicing medicine. In some states, it's mandatory, so you want to ensure that when there is a result, a positive result, or the patient is definitively diagnosed with the HIV infection, that if your state requires or mandates it, that you contact the partner that is associated with the patient who was diagnosed with the condition. Annual assessments are also important and should be documented in the medical record. And as part of an annual assessment, it includes prevention, risk factor reduction, and a follow-up care plan. In some states, as it pertains to partner counseling and partner notification, it may also require that you document the need for domestic violence screening. So again, it varies from state to state. You should follow up with your local Medicaid agency to find out if these requirements are mandated in your state. Okay, so we just spoke about this. Oh, I'm sorry. So in terms of the types of testing, most states suggest that the providers use a rapid HIV test. It's a point-of-care test. The results are given right on the spot, but it is up to the provider's discretion whether or not they want to use the rapid HIV screen or if they want to use the conventional method where the test is performed and it's sent to a lab and you wait for the results. So it's totally up to the provider's discretion that will determine which type of testing they want to perform. So let's talk about our our second code set in the installment series. Today we'll look at the pathology and laboratory section. The pathology and laboratory section, CPT codes, was part of a complete manual that was developed by the American Medical Association in 1966. The CPT code book itself is updated annually and available in January. And just an overview of the code sets, not just specific to the path lab, but for the entire CPT code manual. The codes are used to describe procedures and services that are performed to treat medical conditions. They're performed in the outpatient basis, but as I indicated in the previous installment, in some instances, the CPT codes are also used in other settings, such as the inpatient hospital setting, the ambulatory surgery setting. Another type of codes that is commonly used to report these services are HixPix codes, and the acronym HixPix stands for Healthcare Common Procedure Coding System. This code set was developed by CMS, Centers for Medicare and Medicaid Services, in 1983. These codes are also updated and available every January, and the HixPix codes describe certain procedures and services that are used as a supplement to the codes in the CPT coding book. Now, in terms of the codes itself, approximately 80% of the HixPix codes cross-map to CPT codes. You want to follow up with your local Medicaid state agency to determine whether they want you to report HixPix codes or whether they want you to report CPT codes in those instances where there's a code for HixPix and a code for CPT. If there's only one code, whether it's a CPT or a HixPix, then you would just report the one code. And when we get to the slides, which is now, you'll see the distinct differences in the codes. So this slide gives you an overview of the HIV test codes. These codes here are specific to the antibody. So the first code is your CPT 86701, which is an HIV-1 single result test. The 86701, the 702, and the 03, along with the G0435, these are all designated as rapid screen tests. So if you're performing rapid HIV point-of-care testing in your facilities, depending on the type of test, would determine which one of the codes you would report for the rapid test. And the most common that are used in the industry are the Alair Determine, the OraSure Technology OraQuick Advance, the Trinity Biotech Unigold. Those are the top most commonly used rapid point-of-care HIV screening tests. The state Medicaid agencies typically pay for one test every 6 months. But again, this is not etched in stone, so you should follow up with your local Medicaid state agency to find out what their specific guidelines are. But typically, one test is payable every 6 months. The venipuncture, the code for venipuncture is routine, the CPT code for routine venipuncture is 36415. Typically, this code would not be reported with the point-of-care tests. So when we get to the next slide, if you're performing the HIV testing through blood or urine samples, you should be, for the routine venipuncture only, where you're collecting blood, you would also report this 36415 code. So we'll look at that now. So these codes here are your HIV antigen testing codes. And so these codes are typically reported by, not reported in a facility setting by the physician. Typically these codes will be reported if they are sent out to a freestanding lab for processing, or maybe perhaps you have a lab on site that is responsible for processing your specimens. So dependent upon the type of facility where you are providing these services would determine which type of test code you would use. So if you're doing point-of-care testing, then the top codes that you should be looking at reporting would be one of the 4 here. And if you are doing the blood work and you're sending it out to a lab, or you're sending it downstairs to your on-site lab, the lab would be reporting one of these codes. You would not need to report these codes as a physician. So let's talk about modifiers. So modifiers are 2-digit numeric or alphanumeric qualifiers, even though it says codes here. They're qualifiers that are appended to codes that are used to indicate that a procedure or service has been changed, but the definition of that code in question does not change. It doesn't alter that procedure. There are 2 types of modifiers. There are CPT modifiers, and there are HixPix modifiers. So during this presentation, we will look at a CPT modifier, and we will also look at a HixPix modifier. Modifiers impact reimbursement. Sometimes you, depending on the payer, you may get additional reimbursement, or they may decrease your reimbursement depending on the type of modifier that you're using and depending on the report a modifier alone. Modifiers are never appended to the ICD-9 codes. Oops, I'm sorry about that. Let's take that. Modifiers are never reported on ICD-9 codes. And when we get to Series 3, we will look at ICD-9 codes in detail. You should follow up with your local state Medicaid agency to find out which modifiers are approved for the services that you're providing, because There's always going to be a discrepancy in the coding guidelines in comparison to the billing guidelines. The coding guidelines just give you a general overview of what services, what codes you use for the services that you're performing. But the payers ultimately determine what your reimbursement is going to be. And so if they have conflicting rules and regulations that don't coincide with the coding guidelines, you should be following the payer's instructions, because those instructions will result in reimbursement for your facility. So the first modifier that we're going to look at is Modifier 92. Modifier 92's description is alternative laboratory platform testing. And for the purposes of the definition, when a laboratory test is being performed using a kit or transportable instrument that wholly or in part consists of a single-use disposable analytic chamber, the services may be identified by adding Modifier 92. So the most common use of this modifier are these codes, the 86701 through 86703. And let's just go back to the slide where you can, okay. So here are the codes where the Modifier 92 is most commonly reported with: 86701, 86702, and 86703. Those are your coding guidelines. You should check with your local Medicaid agency, because in some states, this modifier can be used with the other lab codes that were on that slide, the J codes as well. But again, the coding guidelines state you can only use them with the CPT codes. The billing guidelines state that you can also use it with your HixPix codes. All right, so I'm going to just get rid of that and go back to slide 18. The next modifier is your Modifier QW. Modifier QW is a HixPix modifier, and the description of Modifier QW is CLIA Wave Test. The acronym CLIA stands for Clinical Laboratory Improvement Amendments of 1988. And in terms of the use of this modifier, it basically is used to describe a CLIA Wave test that has been cleared by the Food and Drug Administration. Basically, in short, simple terms, it's a simple test that's performed point of care, that has a low risk of error, and it is approved under the waiver program under CMS. We said CMS stands for Centers for Medicare and Medicaid Services. So according to the coding guidelines, this modifier can be used on any of the codes that we looked at on slides 15 and 16. So that's 86701 through 86703, and your G0433 through G0435. So any of those tests that state simple are approved for this modifier. Go back here. Give me 1 second, I'm sorry. Here we go. So any of the codes that are listed on this slide typically correlate with the Modifier QW. But again, just in terms of the reimbursement criteria, you want to make sure that you follow up with your local Medicaid state agency, because they have the specific guidelines and criteria in place for the modifiers that you should be using in your facilities for the services that you're performing. It is inappropriate for you to bundle and use Modifier 92 and Modifier QW together. You either use the one Modifier 92 or the Modifier QW, depending on what your local Medicaid state agency rules are in place. It is also important to note that if during an encounter with a patient, if a combination of wave and non-wave tests are performed, you should not be using this modifier. So again, in some states, they tell you that you can use the modifier. So keep in mind that the rules that are here are specific to the coding guidelines, and it's rather difficult to try to interpret each individual state's requirements, so you should follow up with your local state to find out what their specific requirements are. So let's take a moment to look at a couple of examples. Well, why don't we do this, because I think I see a question on the floor. I see a few questions. Okay. So the first question, oh, they were asking about examples. So we have some examples here. So the first example is a rapid HIV test for a patient that presents for preventive care. Preventive care was covered in Series 1. Preventive care is a patient presents where they are not sick and they have no medical complaints, but they're just there for their annual well-visit exam. So in this series, because we're only talking about the HIV test code, we'll only be looking at the test code and how the code is reported. So this is an example of a 27-year-old patient who comes to their PCP concerned about recently having unprotected sex, and they request an HIV test. Since the physician notes that there hasn't been a well visit that year, the physician decides to perform a well visit, which is an acceptable process. You can perform a well visit during a regular routine request from a patient that comes in for counseling or for HIV testing. So 35 minutes is spent with the patient doing counseling, and the physician does a complete well visit exam and then also reports the test. Now this is an established patient, but again, we're not reporting the established patient code for this series. But if you were reporting this particular scenario to an insurance company, you would have two codes. You would have the code for the well visit established patient component of the visit, and also the code that designates that the patient had a point of care HIV test during the well visit encounter. So depending upon which state you're in, you would report either the Modifier 92 or Modifier QW. So remember, you report either one, not both. This next slide just basically gives you the rationale for the reason for selecting the code. This is an established patient visit. They came in for testing. The record does not state that this is an HIV-2 test. And when we get to ICD-9, we will further discuss the difference between an HIV-1 versus HIV-2 diagnosis, because in coding there is a difference. On the clinical side, there may not be a distinction, but on the coding side, there is a distinction. Okay. So to further the modifier we established based on your based on your local Medicaid agency, the modifier that you would be using would either be a 92 or a QW. These would be the only two modifiers that would be utilized for this point of care HIV test. And so again, just to do a quick look back at the codes, sorry, the codes are here. So 86701 is a single result test. So the final answer for the scenario that we were just looking at was 86701. The note at the bottom of the, yes.
Stacey, it's Michael. We have a question regarding case study 1 from Renee. Her question is, if the provider, as a standard of care, does HIV testing for all patients who present for annual visits, not an individual visit, with a blood draw, not a rapid test, does that impact the code selection?
So you want to know if the patient, so all your patients, you have a standard where you just routinely do a test during the well visit? Is that what the question is?
Yes.
Well, you're not doing the rapid test. You're doing the regular screening test that's sent to the lab?
That is correct.
So then in that case, you would not be using these codes at all. The only code that you would be reporting would be the well visit codes, which we discussed in Series 1. And we have complete examples in Series 4 where you see the CPT for the well visit, the screening test, and the diagnosis code. So what we did for the PowerPoint series is we thought it was better to show it in piecemeal so that you can build on the process for correct coding. So in this instance, for the example, or rather for the question that you asked, your code would be a well visit. So if it's a new patient, it would be a 99381 through 99387. And the routine venipuncture code 36415, because you have made the decision to, sorry, I'm just going back to the slide, because in the case that you described, you're sending your specimens out to the lab for processing. So you would use 99381, and I apologize. Let's say it's, I'm going to use 7. Let's say it's a 65-year-old, and I'm just making that up, that you've seen for that first encounter. So 99387, this is a new patient visit. You'll put a modifier 25 here, and then you would also report 36415, because you're going to draw blood as part of this assessment for the screening, for the HIV screening, and you're going to send it out to the lab. So the lab would be responsible for reporting the code on their end, because they're the ones that's processing the specimen. And there are some examples here in the slide that provide you details regarding the distinction between point of care testing is if you're sending it to your lab. Does that answer the question?
Yes, it does. Thanks.
Okay. So I'm going to go back. So that's case study number 1. Case study number 2 is basically the same. The only distinction is this is counseling. So again, if the patient presents, let's say your patient presents for counseling and then they also have a test, the provider spends 30 minutes counseling the patient. The CPT code that the provider will report for the counseling is 99402. And again, these codes were discussed in Series 1. You would append a modifier 25. And if you're doing the point of care test, then you would report 86701. And depending on your payer, it would be either a 92 modifier or a QW modifier. And again, if this is a PCP that's doing a point of care test where the results will be administered the same day. If you're drawing blood work, then you should not be using this code. The next PowerPoint series, after we discuss this rationale, will provide you an overview of how to report those that are specific to when the labs are sent out for processing. So again, this scenario doesn't state anything about HIV Test 2. So the CPT code that was selected was 86701. The modifier 92, if it's applicable in your state, or the modifier QW. So it's either or, not both. The next scenario is HIV counseling, HIV testing with counseling. And because this is not a point of care test, this code is specific to when the specimen is, when there's blood work drawn and the specimen is sent to the lab. So let's say, for example, because in some of the facilities where I've done audits, they have a lab facility on site where the PCP can either draw the specimen and send the specimen downstairs, or the PCP sends the patient downstairs where there's an on-site lab. And so if that's the case, the PCP would not be reporting these codes. These are the codes if you have a lab lab on-site or if the lab is off-site and it's affiliated with your facility. If it's just the PCP, depending on, since this one is a counseling visit, and that says 35 minutes, the PCP would report 99402, Modifier 25, and also 36415 because there was some blood work drawn. Now keep in mind, in some states, the payer may tell you not to report Modifier 25. They may just tell you to report the codes in this manner. So you have to check with your state Medicaid agency to find out what their specific and coding requirements are. Some states require Modifier 25, some states don't require it. But this slide here is specifically targeted to the facilities that have a lab on site, and these would be the codes that the lab would report, not the provider. Again, here's the rationale. PCP can only bill for point-of-care tests. Since there is a lab on site, the pathologist would be the one responsible for reporting the codes. And depending on, again, your local Medicaid agency, you would append either a Modifier 92 or a Modifier QW. All right. The next one is a similar situation. This one is a confirmatory HIV testing, and I think there's a question. The question on the floor is, so what if you have a draw stand to draw the blood, which is part of the hospital system, sent from the clinic into the hospital for processing? And I'm not sure I understand the question. So what I think the question is asking is if you have a lab on site and the labs are billed by the hospital, and if that's the question, my answer would be then the lab that is on site should not be billing, because it sounds like to me the hospital would be billing those services. So then in that case, the only bill that would drop from your facility would be the bill for the PCP, and that would be either a counseling visit code or, well, it's going to be a counseling visit code. And someone's asking another question. I'll ask my Medicare rep, which is better, 92 or QW. Is there a chance that commercial insurances will prefer the opposite code? The answer to that is, depending on the contracts, yes. In some states, these codes may not be reimbursed. So for the states where the reimbursement is not approved for the counseling codes, you may very well have to use the regular E&M visit codes, because again, a service was provided. And I'm just going to use an example. Let's say the patient came in, they were counseled, they did the test. I would probably use the 99212 because the 9213 is a little high, and it implies that the patient has other medical conditions that the provider was treating. And in this case, really, there were no medical problems. There was just the need for testing and counseling. There's another question. What about the venipuncture code? Could the clinic charge this code if the lab processes it? The answer is yes. So again, if you are a facility that has a lab on site, but the hospital bills for those services, then you as the provider that's doing the HIV testing and counseling would report 99402 with 36415. The 36415 is for the venipuncture. And if you live in a state where counseling codes are not reimbursed, then you would bill 99212. And I apologize, writing with these crayons are a little complex. 99212, Modifier 25, and 36415. So you would bill for the venipuncture code because you are drawing the bloods. the lab that will be processing the specimen will be responsible for processing the specimen and billing the insurance carrier for the respective codes that they're using. And another question on the floor is, from the CDC's perspective, while point-of-care testing in clinical settings may be optimal for some patient populations, particularly patients who are unlikely to return for follow-up care, it is not necessarily the optimal choice. And so I'm not sure I understand the question. If this is just a statement, I pose it to the audience. Yes, in some settings you have patients that are likely not to return. And so that's one of the reasons why most of the state Medicaid agencies suggest or prefer that you do the point-of-care tests, because in the cases where patients are non-compliant and they don't return for follow-up care and follow-up visits, they may take the test and they may not return for their results. And you know, it's important that the patient has the results. And you know, really and truly, you don't have any recourse if the patient doesn't return. There's no way for you to really follow up with them. So just in terms of the health plans that I've consulted for in the past, I strongly recommend that they do the point-of-care testing, especially in those communities where you have a high incidence of non-compliance, where patients don't return for their appointments. Alrighty. So the next one we were just getting ready to look at was the confirmatory test. So this is a high-risk patient that presents for a follow-up. In the previous visit, there was an inconclusive test, and the physician advised the patient to come back in for the confirmatory test. So again, there was some counseling involved. The patient was counseled for 15 minutes, and then the test was performed. And the patient was advised to return. So this may very well be one of those patients that may be non-compliant, but in the case of the care that was provided, in terms of the scenario, the previous results were inconclusive. So the patient hopefully will return after this particular test for their results. So now this is an HIV test performed by the PCP, and the patient was sent down, and it was sent downstairs to the lab. So here again we have the code 86689, and it's going to either be a Modifier 92 or a Modifier QW. So again, you have to check with your payer, your respective state agencies and your Medicaid managed care payers to find out what guidance they suggest or provide for your state. Because here in New York State, for example, the Modifier QW is typically used for these services. The local Medicaid agency doesn't recognize 92. But in another state where I've done consulting, they suggest that Modifier 92 be reported with these services. So it's purely based on the state that determines which modifiers and which codes should be reported. All right. So here's the rationale. Patient presents for a confirmatory test. The code that was reported, 86689. The modifier is either a 92 or a QW, and you should check with your local Medicaid state agency to find out which modifier is appropriate. So some coding tips. If it's a point-of-care rapid HIV test and preventive care is included, you would report the applicable point-of-care test code that was performed on that patient during that encounter. So I'm just going to go back real quick to the slide. Those point-of-care rapid codes are G0435, 86701, 86702, 86701 is HIV-1 single result. 86702 is HIV-2 single result. The 86703 is a combo test. And the G0435 is also a combo test. So it's dependent on the process or the procedures that are performed typically in your facilities. Okay, I apologize. I think that was slide 28. Yes. Okay. If it's a point of care rapid, including counseling, again, it's going to be the same code. So depending on whether it's a single test or whether it's a combo test would determine which code you select. If it's a confirmatory test and it's processed by the pathologist, then you will report one of the codes for the non-rapid testing. And the codes for the non-rapid testing are on slide 16. So let's jump back to 16 real quick. So here are all of the codes that designate tests that are performed and reported by a pathologist. And the exception to this rule would be if the tests are being billed by your hospital facility instead of the actual facility where the test was performed, because that also may be something to factor in as you're setting up your EMRs or your hospital templates to get properly reimbursed. The next slide, also it's important to make sure you append the applicable modifier for the rapids as well as for the confirmatory tests. Because for the most part, for the types of tests that are being performed in your facilities, you would have to put a modifier on the code in order to get properly reimbursed, but it's dependent upon what your local Medicaid state agencies have in place. Now there are some codes, your CPT code 87389, so let's just take a look at that. It's an antigen test, and I'm going to go back and look at it real quick. But the CPT code 87389 includes a rapid and the HIV-1 antigen. And the antigen codes are these three codes here. So let's just go back really quick before I finish my sentence. So the 87839 is this code here, and it includes an HIV-1 antibody with the HIV-1 and 2 antigen. And so this is designated as a combo test. It's a test that's performed by the pathologist, or rather the provider, they draw the blood, but ultimately the test is sent to the pathologist for processing. And so in those instances where this type of test is performed, the correct code that would be reported would be the combo test. All of these codes, 86703, 87535, 87536, and 87390, they all bundle and roll up into this one code here. So if you were to separately report all of these codes for the services that were rendered, that's considered unbundling, and typically the insurance companies don't particularly find that to be compliant when you unbundle and bill services separately for the purposes of increasing your reimbursement. So you want to be careful and know that if you're performing this combo bundle service, that this is the only one code that you should be reporting, and that for the modifiers that are specific to this one, you contact your local Medicaid agency for guidance. So we're wrapping up. These are the web resources that were used to prepare this webinar: the Centers for Medicare and Medicaid Services, the Food and Drug Administration, the American Medical Association, and the National Center for Health Statistics, and also the Centers for Disease Control. Additional web resources, these are specific to coding. And so your coding resources are the American Academy of Professional Coders, the American Health Information Management Association, the American Academy of Family Medicine, and the American Hospital Association. So these are your coding resources. Additional coding resources that were used for this presentation was the CPT coding book by the AMA, the HixPix coding book by Centers for Medicare and Medicaid Services, but the publisher is Ingenix, and also a pocket guide. I'm going to turn the presentation back over to Michael so that he can take it from here.
Thank you, Stacy. Appreciate your detailed presentation for us today. I just want to remind folks that we do have both a desk reference, the slide deck, and the web recordings of these webinars will be hosted on the healthhiv.org website. If you go to the main page, we do have a link right on the front of the website for you to find that material. The live recording of the webinar will be available within the next hour on the site. Additionally, Stacy has prepared for us today a guide to talking with state Medicaid offices in asking questions about denials and claims. This reference is a tool to be used to ask the correct questions. Additionally, if you have questions and answers, questions that you would like to pose to Stacy, we will be taking a few questions still today. You may use the question and answer box at the bottom of the screen in order to ask those questions. Stacy, we do have a question that has been posed by Irene. Can a practice charge for an HIV can a practice charge for HIV testing performed by a certified HIV counselor and tester when a patient presents for a test? Does the test have to be performed by a PCP?
Okay, so the answer to that question is an order set has to be placed in the system in order for these services to be reported by, well, let me ask this question. Are the services being reported by the counselor or by the PCP? Because there's potentially two answers. If you are in a state where your local state Medicaid agency recognizes certified counselors and they allow them to report the testing codes, then you don't need the provider to place the order set. But if you are in a state where the local Medicaid agency does not recognize the counselors, then the provider has to ultimately be the first point of reference where that the patient sees before getting their blood work drawn or before having any type of test done. So ideally what would happen is the patient would see the provider first, and the provider would do all of the other elements of the visit and then put an order set in the system and would inform the patient that they're not going to see the counselor, and the counselor will be doing all of the HIV counseling and testing components. And then the visit would be billed under the provider. So this order, there has to be an order set in the system, and it has to tie this service that was performed by the counselor has to tie back to the order set that the provider has in the system, and the bill would go out under the provider.
Thank you. Stacy, there is another question being posed by Renee. Many providers have noted that they have a difficult time getting reimbursed for point-of-care rapid tests. Blood draws with a lab are much easier for reimbursement. Can you speak to the reason why that may be the case?
Yeah. Now, again, things are done. I guess the reimbursement guidelines processes are different from state to state. Because here, for example, in New York, we don't have that problem. We get paid for the point-of-care testing. In addition, sometimes it is necessary after the point-of-care test to go on further and do the full HIV or AIDS test, and they pay for both those. So you have to ideally follow up with the payers and the local Medicaid agency to find out how they want you to bill for those services, and you would follow their advice and instructions. And so again, because it varies from state to state, it's a little difficult to say, why they're not paying or why they will pay.
And Doug asks that we frequently do HIV testing with STD, gonorrhea, chlamydia, syphilis. Is there a CPT code that includes all 4 tests?
Unfortunately, there is not. Yeah, you have to report each test separately. So there's a rapid, I think there's a rapid chlamydia. I'm not sure if there is a rapid gonorrhea or a rapid syphilis test. So there is a code for the rapid chlamydia screen, but there's also a code for those instances where the services is reported by the lab instead of by the PCP. But to answer the question, no, there is not a separate code. You have to report each service separately. And that includes also the diagnosis. You have to report a separate diagnosis as well, because in most practices where I've done some consulting, they're only reporting one code and they're losing reimbursement, and they're not reporting the correct diagnosis code, and that may also tie in to the reason for denial. If you're performing multiple services but you only have one diagnosis, the diagnosis, which we will discuss in installment 3, the diagnosis tells the payer for the reason why you needed to perform that service or that test. And if they don't match, it's denied for medical necessity.
A question from Tina. If you are in a setting where all services are bundled, for example, inpatient or FQHCs, how do you suggest coding for maximum reimbursement for HIV tests and services?
Okay, so you're saying that the services are all bundled? And she wants to, okay. So again, we don't have any control. We meaning the providers and billers and coders that work on behalf of the providers. We don't have any control on the reimbursement that the providers decide to issue to healthcare professionals. If they deem that a service is bundled, there's really nothing that you can do about that. You have to follow their requirements. So in some cases, even though there might be a separate code for each service, they may say, well, you did this and we consider it bundled. You have no say in how they're going to reimburse for the service. So what I would do is you should report all of the tests separately, because there are going to be payers that will reimburse for everything, and there will be payers that will not reimburse for everything. When you set up the codes in your system, you should set it up such that you have fee schedules so that you know which health plans and which payers reimburse and which ones do not reimburse. But there's really no way of knowing which plans across the board reimburse for separate tests, and there's really no way of determining what's bundled and unbundled unless you've actually submitted claims data and you have historic data in your system.
And from Shirley, we will be doing rapid HIV testing along with TB testing. They are to be reported separately.
Absolutely. There's a separate code for HIV testing, and there's a separate code for TB testing. And I believe off the top of my head, the code for the TB test is 86850 or something in that family.
Terrific. And a question from Gina. Do nurses qualify as providers, or is that dependent on the state?
So the nurses that qualify as providers are your nurse practitioners, but also, yes, it depends on the state, and it also depends on the contract, how the contracts are negotiated, because here in New York, in some of the facilities that I've consulted for, NPs can bill separately on behalf of themselves, but the reimbursement is reduced for an NP versus an NP, nurse practitioner, versus an MD, medical doctor. So, for example, here in New York, the reimbursement would be reduced by 15%. So an NP, if the contract is negotiated to allow for reimbursement, would be 85%. And again, it varies from state to state. And so some states may not allow an NP to separately bill or be reimbursed for any services.
Terrific. Thank you so much, Stacy. I believe that concludes all of our questions for today. If you have additional questions, please feel free to email them to me at michael@healthhiv.org, and we will forward them on for Stacy to provide feedback on. I would like to remind participants that we have the 2 additional webinars coming up next week. On Tuesday, March 18th, the HIV diagnosis codes, and on Thursday, March 20th, we will be having a webinar on coding scenarios, which we will review various scenarios in which coding where we will apply all of our lessons learned thus far. Additionally, I would like to remind individuals of our Fiscal Health from Systems to Sustainability program. This is Health HIV's capacity building to Ryan White grantees. For more information about that program, you can access our website or email Julio Fonseca at julio@healthhiv.org. And to request capacity building services from the National Center for Healthcare Capacity Building, please feel free to email me, michael@healthhiv.org. Within 1 hour of our presentation ending today, we will host our webinar. Will be hosted on the healthhiv.org website along with the slide decks today. All of the questions will be answered in written format, and they will be available within 1 week of the call today. I'd like to thank you all for participating and look forward to you joining our call and webinar next Wednesday. Thank you.